For decades, the reflex teaching was incredibly simple. If you have an asthma attack, you just reach for the blue inhaler, right? Well, what if I told you that advice is now considered so fundamentally flawed that current global guidance actively recommends against treating adults and adolescents with just a short-acting bronchodilator alone? Okay, let's dive into this. We are talking about a total, ground-up reversal of how we approach this condition, even for the mildest, most occasional symptoms.
Welcome to this explainer, where we're going to break down asthma from absolute first principles. We really need to understand exactly what is happening in the airway to see why the old approach was, well, treating the wrong half of the disease. By the time we wrap this up, you'll see exactly why relying solely on that blue inhaler simply stopped being good enough.
Okay, let's quickly check out our roadmap for today. We'll be covering the blue inhaler trap, 2 problems, 1 disease, the track 1 solution, diagnosing the airway, exacerbation red flags, and finally, management and discharge. Let's get right into it. Section 1, the blue inhaler trap. So here's the stark reality about that trusty blue inhaler. Relying purely on a short-acting beta agonist, or SABA, provides incredibly effective, lightning-fast bronchodilation. Patients take a puff and they feel fine. Actually, scratch that, they feel instantly relieved. But that is exactly the trap. Because that blue inhaler does absolutely nothing for the underlying inflammation, frequent SABA use leaves the airway totally unprotected. This false reassurance, feeling great while your airway is quite literally on fire, is now understood to genuinely increase the risk of severe exacerbations and, tragically, even asthma-related death. This is exactly why current global guidance dictates that essentially all adults and adolescents with asthma need inhaled corticosteroid therapy, no matter how mild their symptoms seem. Moving on to Section 2. 2 problems, 1 disease. Think of it like this. Asthma isn't just one problem. It's a giant 2-part puzzle. On the left, we've got the upstream cause, airway inflammation, which is driven by eosinophils, mast cells, and T cells infiltrating the airway wall. Then on the right, we have the downstream symptom, bronchoconstriction. That's the smooth muscle spasm that actually narrows the airway and creates that classic wheeze. The critical flaw in the old treatment model, by treating only the muscle spasm on the right, it completely ignored the upstream inflammatory fire on the left. It's like turning off a fire alarm while the house is still burning down. Section 3, the track 1 solution.
All right, so how do we fix this? The answer is a real game changer called MART, or Maintenance and Reliever Therapy. The medical community desperately needed a mechanism-based solution, and they found it in a specific medication called formoterol. Unlike most long-acting beta agonists, formoterol acts incredibly fast, just like a short-acting blue inhaler, but it lasts a really long time. When you combine formoterol with a low-dose inhaled corticosteroid, or ICS, in a single inhaler, you get pure magic. You get that immediate symptom relief, plus a perfectly timed dose of anti-inflammatory treatment exactly when the triggered airway is flaring up. This totally reshapes our approach, which you can see in the GINA 2024 and 2025 guidelines 2-track framework. On the left, we've got track 1. This is the preferred approach, using that anti-inflammatory reliever therapy in a single ICS-formoterol inhaler. It's actively preferred because it heavily reduces exacerbation risks, oral steroid bursts, and trips to the ER. Over on the right is track 2, which is the older model, a daily maintenance ICS paired with a separate SABA for emergencies. Today, track 2 is really only recommended as a backup plan in settings where those combination inhalers just aren't practically accessible.
Let's see how this builds a highly effective, incredibly elegant treatment ladder. Within track 1, you're using the exact same core inhaler at practically every stage. For the mildest cases in step 1, patients use low-dose ICS-formoterol purely as needed. As symptoms get a bit more persistent in step 2, they step up to daily MART, taking a fixed daily dose while still using that exact same inhaler for rescue. And if things are still poorly controlled by step 3, we just increase the MART dose and maybe add a long-acting muscarinic antagonist or LAMA. Still uncontrolled? Then we start looking at targeted biologic therapies based on their specific inflammatory biomarkers. But notice the trend? It's one core inhaler, escalating smoothly. Section 4, diagnosing the airway. But before we commit anyone to these tracks, we need a rock-solid diagnosis. The gold standard here is spirometry. What we're hunting for is an obstructive pattern with significant reversibility. And here are the magic numbers to burn into your memory. An FEV1 increase of at least 12% and at least 200 milliliters after giving a bronchodilator. Hitting that confirms the diagnosis. However, and this is a really big however, a perfectly normal spirometry reading in an asymptomatic patient absolutely does not rule out asthma, Why? Because airway function can completely normalize between episodes.
Now, if formal spirometry just isn't accessible, don't panic. We have other tools. A peak flow variability of greater than 20% between the highest and lowest readings is a fantastic supportive alternative. On the flip side, a methacholine challenge test is excellent for ruling asthma out if the result is completely normal. And for those severe phenotypes we talked about a minute ago, measuring fractionally exhaled nitric oxide, or FeNO, and blood eosinophils becomes absolutely vital. These are specific markers in the breath and blood that tell us exactly which type 2 inflammatory pathway is misbehaving, which lets us precision target those fancy biologic therapies instead of just blindly escalating inhalers.
Which brings us to Section 5, Acute Exacerbation Red Flags.
When things go south and a patient hits the emergency room, we rely on a very structured matrix to figure out the exact urgency of the situation. Acute severe asthma features a peak flow between 33 and 50%, a high respiratory or heart rate, or maybe the inability to complete a full sentence. But life-threatening asthma, that is a totally different ballgame. Peak flow drops below 33%, oxygen sats plummet below 92%, and you might see a silent chest, exhaustion, or hypotension. And then there's near-fatal asthma, which is marked by the need for mechanical ventilation. But I want you to look really closely at the PaCO2 row on this table.
I literally cannot emphasize this enough. If you have a severely breathless asthmatic patient, they should be hyperventilating and blowing off massive amounts of carbon dioxide, right? So their PaCO2 should be low. If you pull an arterial blood gas and that PaCO2 comes back as normal, that is absolutely not a reassurance. It is a massive screaming red flag. It means the patient is exhausting themselves, their respiratory muscles are failing, and they are actively losing the ability to ventilate. A normal or rising PaCO2 means impending respiratory failure.
So how do we actually manage this acute crisis in the moment? First up, oxygen, to maintain sats between 94 and 98%. Second, nebulized beta-2 agonists, and you can potentially add nebulized ipratropium if their initial response is poor. Third, and this is absolutely crucial, systemic corticosteroids, either early oral or IV. Think back to our first principles. The steroids are the fire extinguisher that actually puts out the underlying inflammatory fire causing the whole event. Finally, for patients with a really poor initial response, a single dose of intravenous magnesium sulfate can be considered. And please, make sure you do not confuse this with nebulized magnesium, which is specifically not recommended in adults.
Finally, Section 6, Management and Discharge.
Look, if you send a patient home without figuring out exactly why they flared up in the first place, you've basically failed them. Surviving the ER is only half the battle. Here is a systematic 6-step discharge process. 1. Formally reassess their asthma control. 2. Check their treatment adherence. 3. Physically watch them use their inhaler to check their technique. Do not just assume they know how to do it. 4. Provide a concrete written action plan. 5. Actively treat any allergic rhinitis that might be secretly worsening their control. And 6. Identify their allergen triggers. Skipping this structured review is exactly how patients end up relapsing and bouncing right back into the hospital a few weeks later. So, I'm going to leave you with this provocative question. The next time you see someone reaching for a blue inhaler, ask yourself, are they treating the symptom or are they treating the disease? Because treating one without the other is exactly the gap modern medicine is trying to close. If you found this explainer valuable, please drop a like, leave a comment with your thoughts, suggest some topics you'd love to see explained next, and absolutely hit that subscribe button for more deep dives. Thanks so much for learning with me today.